Dr. Adiola, are you there?
Yes, please.
Yes, ma'am.
Yeah, welcome.
Good afternoon, all. I present the citation of Professor Uche Anadu Ndefo. Professor Ndefo obtained both her pre-pharmacy and Doctor of Pharmacy degrees from the University of South Carolina, Columbia, in the year 2000 and 2003, respectively. She started her career as a full-time pharmacist at the CVS Pharmacy US in 2003 and works there till date. She also worked as a managed care pharmacy practice resident and clinical informatics manager at Cater Permanent Regional Office, Georgia region from 2004 to 2007. Her academic experience spans from being an assistant professor in 2007, associate professor in 2013, to a full professor of pharmacy practice at the College of Pharmacy and Health Sciences, Texas Southern University, Houston, Texas in 2019. Professor Ndefo possesses an array of certifications in pharmacotherapy, pharmacy immunization delivery, cardiopulmonary resuscitation basic life sciences, speaking for health professors, and medication therapy management trainer. Professor Ndefo has published and presented varied academic content, received funded grants for research, and is a recipient of numerous honors and awards, which include Protector of the Year at various times at Cater Permanent and Texas Southern University. Professor Ndefo is a member of Nigerian Association of Pharmacists and Pharmaceutical Sciences in the Americas, NAPSA, where she currently chairs the Education Committee. Professor Ndefo also serves on a few editorial boards of pharmacy journals. I have the honor of presenting Professor Uche Anadu Ndefo as the first facilitator at today's clinical meeting. Thank you.
Thank you.
Do I take the second slide?
For our presentation today, we have 60 minutes. 25 minutes will be for each speaker, and we have 10 minutes for the three contributions that will be a pharmacist, a doctor, and a nurse. The question will be forwarded using in-meeting chat. So in case our time runs out after 1 hour, in order to attend to our questions, we will log in with the same meeting ID for an extra time of 15 or 20 minutes with the permission of our guest speakers. So once again, I want to welcome our first speaker for today, Professor Uche. You are welcome.
Good afternoon, everybody.
Yes, you are welcome.
Thank you, Dr. Adil, very much for that wonderful introduction. I appreciate it. I remember you very clearly from the Pharm D program. Okay, so without further ado, I'll just go ahead and get started. The previous speaker mentioned, I will be talking about using evidence-based guidelines for pharmacy practice. And I want to start with the question, what is evidence-based medicine? Now, I know that a lot of us have WhatsApp, am I correct? Everybody here has WhatsApp on their phone, and you get all those forwards by people telling you all the different things that you can do to stay healthy, especially in the times of COVID-19. And I always cringe when I get those messages from pharmacists, because I know that we know that these things have to be evidence-based. And it's questionable how much of the information we're receiving is evidence-based, because there's barely enough evidence as is, because this disease state is so new. So the first quote I have is from a physician, David Sackett, who says that evidence-based medicine is the conscientious, explicit, and judicious use of the current best evidence in making decisions about the care of individual patients. A different way to think about it is, before you make a decision, asking yourself, why am I doing it this way? Is there evidence that can guide me to a better outcome? Okay, so there has to be a reason behind why we decide how to treat our patients. So some official definitions: evidence-based medicine is defined as the use of best evidence, current best evidence from research to make practice and policy decisions. It is a shift away from making healthcare decisions on opinion, precedent, or past practice. So we're no longer saying, I'm going to treat this patient because I think this is the best way to do it. I'm going to recommend this medication for a patient because that's how I've always done it, right? We want to make sure that we're using more science and research to guide the clinical decision making.
Can you speak louder?
Yes, sorry. Are you having a hard time hearing me?
Thank you.
Okay, is that better?
Yeah, okay, it's okay.
Okay.
You can go on.
So we are trying to move away from using our opinions or what we've done in the past and making sure that the decisions we're making are science-based and there's research to support that. Not to say that your individual clinical experience is not important, but we're integrating that individual clinical experience with the best available external clinical evidence. So if you think about what research is, and I know that we all know what research is, but it is a systematic scientific process that helps generate new knowledge or helps us validate existing knowledge. There's a research question, we review current literature, and then we pose the research question. Then there's an intervention. After that intervention, we look at the results, we analyze the data, and then we can disseminate the results of that research. So once we have that research, we now have the evidence that we need to be able to provide evidence-based care. However, there are different ways to stratify that evidence. There are different levels of evidence. Level 1, and this is just one way to stratify evidence. This is from the US Preventive Task Force. And depending on what resource you're using, there are different ways that evidence is stratified. So this is just one example of ways that you can consider evidence. So level 1 here is evidence that's obtained from at least one properly designed randomized controlled trial. And then it continues to go down. Evidence obtained from well-designed controlled trials, but maybe that trial did not have randomization. And then evidence designed from or obtained from well-designed cohort or case-controlled studies, preferably from more than one research center or group. So there are different levels of evidence, and as you can see, the very bottom is opinions of selected authorities. So we still regard that very highly, but those opinions are at the lowest level of evidence because those authorities, we understand, have the practical experience, right? However, if those results are not reproducible, then we really don't want to try them wherever we are. Now, sometimes that's the only evidence we have. Sometimes there's not enough information to be able to have a properly randomized controlled trial. So we have to go with just the evidence that we have, or the opinions of selected authorities, which is a lot of what you are seeing happening right now with COVID. However, what we always want, ideally, is to have at least a properly randomized controlled trial. And then when we have those categories of evidence, we draw different conclusions from that evidence. So this is another example of ways to draw conclusions from evidence. And this is rated A, B, C, D, E. So a category A is saying that there's good scientific evidence that suggests that the benefits substantially outweigh the risks. So the benefit of treating a patient with COVID-19 with chloroquine, does that outweigh the risk, right? If there is nothing else that's working, is it okay for us to just give the patient azithromycin and see if it helps? So in that case, we're saying, well, there's fair scientific evidence that suggests that the benefits might outweigh the risk. Now, there's the risk, I think, at least I remember from my childhood with chloroquine having a lot of itchiness, right? Extreme itchiness whenever I would be exposed to it. So that was the risk for me as an individual taking that particular medication. So knowing that I was going to have that extreme pruritus, that is the risk for me. But if the benefit is that I'm able to breathe better, which might mean that I get to live longer, then I'll take a little itchiness and still have my life, if that makes sense. So the different categories and different ways to categorize the recommendations that you get from the clinical trials that you have reviewed. So sometimes the risks actually outweigh the benefits. So you take something to treat, you take a medication to treat your headache, but you cause yourself to have some cardiovascular disease as an after effect. So at that point, that cardiovascular disease is a risk that outweighs the benefit of no longer having a headache, because you no longer have a headache, but now you've developed cardiovascular disease. And then there are some decisions that there's just no scientific evidence to back it up. What you have is lacking or is of poor quality. So we have an evidence pyramid. And with the evidence pyramid, technically randomized controlled trials are at the very top. Some people question whether meta-analysis or systematic reviews are really supposed to be at the very top of that pyramid, because with those trials, as you are probably aware, you are bringing in different trials and consolidating them into one big trial. And some people really appreciate that science, and some people are not as excited about that science because they feel that those trials are not necessarily done properly because they're not really a trial, they're a combination of trials. But the gold standard is a randomized controlled trial. Then you have cohort studies and case control studies where you've identified patients that have one disease state and you compare them to patients that don't have that disease state and see sort of what the differences are. And then you can also have case series and case reports. And that's a lot of what we're dealing with in today's world, where they say, well, we have this one patient, we treated them with drug A, drug B, and drug C, and X, Y, and Z happened. And we have another patient, we treated them this way, and this happened. And then everybody else says, okay, well, let's see whether that works at our institution. So that you have 10 patients that are treated that way. And sometimes you get the results you're looking for, and sometimes you don't. And there could be something that was unique to that hospital or that institution that made those things work out the way they did. So we don't put as much weight on case series or case reports, but those are a very good place to start and help generate hypotheses. So this evidence pyramid is really just saying that at the end of the day, we really want to be able to have a randomized controlled trial that backs up whatever decisions we are making or whatever recommendations we're making to our healthcare team. One big thing that we rely on are guidelines. So the American Diabetes Association has guidelines, the American College of Cardiology has guidelines, the Infectious Disease Society of America has guidelines. We have guidelines for treating oncology, and we rely very heavily on those guidelines because they are providing us as healthcare providers with a medically proven roadmap for appropriate treatment of a wide variety of conditions. So we have the best scientific evidence and it's put together in one document by our experts. So those guidelines are written by the top experts in that field, and they incorporate the best scientific evidence that's there. And based on that, they make recommendations. And when you're reading through those or using those guidelines for treatment, you have the confidence that it is based on rigorous clinical research and that it's soundly generated, and there is a professional consensus before it became an official guideline. So anytime in your institution you are looking to develop any kind of measures of clinical performance, these guidelines need to be referred to see what it is the guidelines say about these disease states, to make sure that whatever measures you're developing at your institution are actually backed up by these guidelines. Now, this, I talked more on a hospital level, but what if you as a pharmacist are treating a patient? We have something that we abbreviate as Pico, and it is how to develop a well-built clinical question. The first thing you want to identify is who is the patient, or what is the problem that the patient is presenting with? What intervention are you recommending? And then what do you compare your recommendation to? What other options are out there that could come in place of the recommendation that you're making? And then evaluating the outcomes of the recommendation that you have made. So Dr. Adeola knows that I like to throw in real case scenarios so that we can sort of talk through how you would use the information that I'm presenting to you. So this is an example of a patient. He's 78 years old. He has a history of myocardial infarction, and he has dyslipidemia. And his chief complaint today, or he's here today just for his annual physical. And in the process of doing that, we realized that the patient is unable to take a statin due to myopathy despite his high LDL. And the physician who is treating him would like to start him on ezetimibe, which is an option for lowering LDL. So for this patient, what we would do is we would identify him. He's elderly. He has a history of MI. He's suffering from angina, and he has dyslipidemia. The intervention that's recommended right now is ezetimibe, but we know that there's some other options: a bile acid sequestrant, niacin, omega-3 fatty acids, and I'm not sure those are available in Nigeria yet, but the PCSK9 inhibitors. So at this point, we will ask ourselves, which one of these has the evidence that we need for this gentleman? The bile acid sequestrants could work. However, we know that the bile acid sequestrants do cause a lot of gastrointestinal problems. So is it something that we would want to initiate in the 78-year-old man? Niacin is an option that a lot of people like, but we know from recent information that niacin, although it improves the patient's lipid profile by reducing LDL and increasing HDL and reducing triglycerides, that niacin does not actually save lives. Niacin does not reduce the chance for mortality. It does not reduce the chance for cardiovascular events. So we probably would not recommend niacin because we're not treating the patient's lipid profile, we're treating the actual patient. Omega-3 fatty acids have been proven to reduce mortality and cardiovascular events, but they are more effective with reducing triglycerides and not LDL, so that may not be a good option. PCSK9 inhibitors, we generally do not recommend because they are extremely expensive. So we would go through each of these options to compare and figure out what may work best for this patient, because overall what we're trying to do is prevent him from having another heart attack and reduce his chances for mortality. So that's how we use that Pico model in evidence-based medicine. Now, of course, evidence-based medicine sounds wonderful, right? Everybody wants to use it. Everybody knows that this is what you should be doing, but there are some barriers to the use of evidence-based medicine. Sometimes you cannot find a good option. I just went through this 78-year-old patient with you, and there was no good option. There was no clear alternative for him for that ezetimibe, because all the other things I gave you had things that were undesirable for that patient. So we may not have all the information that we would like to have to be able to make a good recommendation. And then sometimes we don't have the confidence in literature searching skills, so we don't have the confidence to come out and say, well, there is no evidence, because we're not sure whether the search we did was comprehensive enough. There's also publication bias, where if I've tried to treat a patient with azithromycin for COVID and it didn't work, I may not take the time to write a paper to publish, hey, drug A did not work for this disease state. Because that doesn't seem like an exciting paper. That doesn't seem like something anybody's going to want to publish. You're publishing a paper just based on something that did not work, right? So I may not even take the time to write up that paper to send it in to someone to publish it. It's also the newness of the concept. Evidence-based medicine is not as new anymore. I think most people have heard of it, but sort of incorporating it into daily practice is what is still new, even for us here. Sometimes there are just no trials that are properly designed. And then sometimes it's also considered, it can be impractical. So you have a patient in front of you. If you don't already have the guidelines at the tip of your fingers, or if you don't already know what the guidelines say, having to stop for every prescription that you're filling or every patient that you're seeing to check to see whether everything that's being done is correct may not be practical in the little amount of time that we have. So where do we find evidence-based medicine? And for my PharmDs in the room, I know that you have already been through this with me, but there is an app that I use on my phone called Hippocrates. If you have an iPhone, you can find that from the App Store, or if you have an Android, then you can find it from your Play Store. But it's called Hippocrates. And if you register, it's actually free to get, and it contains drug information. And the reason I recommend this over all the other ones that are out there is that it also has guideline summaries. So even if you don't have the guidelines at your fingertips, when you have this app, you can look up some of the guidelines depending on the disease state that you're treating. So for my PharmDs in the room, because I know that I had PharmDs from University of Ilorin, I need you guys to help your colleagues and show them how to get this app downloaded so that you are all able to treat patients properly using the app. So I know you probably cannot see it, but I know that your colleagues can help you with this. Okay? So you can see how it's spelled, Hippocrates. And I want you to use that to check your doses. You can check drug interactions, you can identify pills, but most importantly, you can find those guidelines. So any decisions that you're making, especially my drug information pharmacists who are the ones deciding what protocols that you are using to treat patients, you need to have a resource that you're using on a daily basis. The other options that I have here for you, Medline Plus. Medline Plus is actually put together by the US government, and it has drugs and disease states. And I really like it because it explains things in layman's terms. So if you're looking for a way to communicate with your patients in a way that they will understand, a lot of that language contained in Medline Plus is really easy to translate when you need to talk to a patient that may not have a lot of clinical expertise. Package inserts or prescribing information are also a good place to look. The information contained in package inserts or prescribing information have to be approved to be listed in that package insert. So package inserts can be helpful for things like a maximum daily dose of a drug or drug interactions. Those are generally good information to be able to locate in the package inserts or prescribing information. If you have access to a smartphone, you can just put in the drug that you're looking for and the words prescribing information or package insert, and it actually pulls it up for you. The other reference that I wanted to mention is called Google Scholar. So instead of just doing a regular Google search, you can do what is called a Google Scholar search. And you can start off doing that search by just going to google.com, looking up Google Scholar, and then doing the search for the topic that you're interested in. Sorry, say that again? Okay, sorry.
3 minutes more.
3 more minutes?
Yes.
Okay. And then you have PubMed. So Google Scholar and PubMed are places you can go to find the randomized control trials that we discussed. There's also something called a Cochrane Review, which is a free resource if you go to cochranelibrary.com. The Cochrane Library, they actually put together evidence from different things, and then they write a paper that consolidates that evidence into one. So if there's no guideline, the Cochrane Reviews are a good place to look. And then the CDC is the Center for Disease Control and Prevention, and that is a good place to go look for information. People generally think of the CDC as looking mostly at infectious disease, but they actually look at all types of disease states. So when you don't know where else to look, the Centers for Disease Control and Infection, or if you just type in CDC on your search bar, it will come up and you're able to find some information there. So before we make any kind of clinical recommendation as pharmacists, we need to consider efficacy. It needs to be effective. The benefit has to outweigh the risk. Make sure there are no contraindications. Check the warnings and precautions, and also check for adverse reactions before you make a recommendation. One other thing that I find extremely useful is called Physician's First Watch, and it's by the New England Journal of Medicine. Their mission is just to give you information daily for you to be clinically prepared and practice with confidence. You can sign up at the link that I have listed below. I hope you can see it, where you can go on there and sign up for daily emails, and they will send you an email every day with the daily medical studies. They only send them on weekdays. And then at the end of the week, they send a summary of the week's most popular studies. And right now, with everything that's going on, they have a COVID-19 section every day where they send information about new clinical trials or new case reports on COVID and the different ways that they observe those things. So I hope everybody was able to copy that link. It's jwatch.org/medical/news or -news. It's a good place to be able to go to get information to help you stay up to date so that the recommendations you are making are evidence-based. One thing I want you to walk away with today is when you are making a recommendation to members of your healthcare team, it carries a lot more weight if you're able to say, this information is according to the American Diabetes Association, or this information is according to the Infectious Disease Society guidelines. It carries a lot more weight than if you just say, this is what I think. So being able to use that evidence-based guideline will help you be able to work better with your healthcare team and earn their respect as well. Thank you very much